answer to the wrong answer. So I can't say that every time you change your answer, you're probably going to get it wrong, because the ones that you don't change, I don't see those because they're not changed. But just a lot of times, I mean, it happened more than a handful of times on the last quiz where you changed it from the right answer to the wrong answer. I'm like, no. So usually, just go with your gut. You guys don't have as big as one as I have, but but usually your first instinct is right, unless you misread the question or something like that. But so send them all down to the end. Make sure you got your names on them. Then get the names on them. Make sure you pick a good name on it. Do you want to go over the quiz? Okay. So usually I try to go over it in the lecture, but we'll go over it right now while it's still fresh. Okay, so the wisdom of making clinical decisions based solely on the highest level of evidence is being questioned. Oh, did you guys notice who wrote the article? It was a hygienist, yeah. Yeah, she used to work here. She's, so I expect great things from you guys. Mrs. Holbut she's right at the top of the profession when it comes to, well, many things, but caries control is one of them. So that's why I expect lots out of you guys, because in general I expect a ton, and I expect a lot from my hygienists that I work with, so I expect the same from you guys as well. And you guys have some really good role models.
Was the California school she was talking about this school?
I think so. I think she was working with Dr. Novi at the time, but yeah. Anyway, so I got sidetracked 5 minutes in, and I've already gotten sidetracked once. Okay, so why does she say that why is she questioning whether we should use the highest level of evidence all the time in our clinical practice? Yeah. So the answer was variables. Yeah, they're variables. So C. So there's lots of variables going on, and we don't always have all the evidence that we need to make a clinical decision. Okay. What type of research is the highest quality research? Yeah, systemic reviews, with meta-analysis. Yeah. Lots of, you guys are, when you read your journals, you're going to read a lot of stuff written by manufacturers. So you just got to remember, who's writing it, what their biases are, and then that will help you make good decisions. The book that that Barbara included in your list as being helpful for this class is written by a manufacturer. So same thing. There's a lot of good information in there, but you just have to remember who wrote it. Case studies are interesting, but there's so many variables you don't know what went into that case. So they give you a good idea, but they're probably not the same level of, and the case studies and clinical experience are kind of similar. Okay, what does CAMBRA stand for?
Caries.
Yeah, good. I'm trying to give you some freebies in here. Okay, what do you need to have an ideal caries risk assessment? Yeah, all of those things. They're all very good. Okay, what is our best predictor for future caries?
Previous caries.
Yeah, that's like saying the best predictor for divorce is being married. Anyway, that's all we got. Okay. Okay, so good. Let's get started today. I had to make a different title flag because I didn't want to give away the third question. But yes.
Do you ever drop
A question?
like if everyone gets one or
I have dropped it before. I have dropped a question before, but not very often. Yes.
We have midterms Monday, so it's going to be after all of the lectures, or all the rest of the
So I'm pulling the. These are good questions, but maybe better for the after the lecture. But yes, I'm going to be taking the questions from the lectures. The articles are related to the lecture, so there's similar information in there. So you might be able to find the answer to a question in one of your articles. But yeah, I'm just taking them from the lecture. Yeah. So your study guide is the lecture objectives. Yeah. So again, these lecture objectives are just things you need to know. They're not direct questions. So since we're on this subject, there'll be 50 questions, 2 points each. Makes it easy to figure out the percentages. All multiple choice. And they're going to be based off the lecture objectives. Okay? You'll have a proctor, or let's back up a little bit. I requested a proctor, so we'll see how that works out. Okay. All right, so these are some of the, or these are all of the lecture objectives for today. So you guys already know the definition of Canberra. We're going to go over how the Canberra model kind of differs from the traditional medical model a little bit. We're going to review the Caries balance and imbalance part of Caries risk assessment. So we're going to go into a lot of details. You're going to have to know what the disease indicators are for Caries risk assessment, the risk factors and the protective factors. You need to understand how the risk assessment is calculated or determined. And then at the end, we're going to go over some of the guidelines for both children and adults, treatment guidelines based on the Caries risk. Okay. So not too much, right? Okay, you guys already know this, the Caries management by risk assessment. So we're using the best evidence available to decide how to prevent and, if possible, reverse the Caries disease. And if we can't reverse it, then we'll try to repair it. The damage from Caries, the disease. Okay, so Caries would be really easy if we just had, like, for influenza or something where there's just one bug that makes the disease, and you just get a vaccination and poof, you're good to go. Except that Caries, like from the very first lecture that we went over, Caries has a bunch of different pathogens that contribute to the disease, and there's a bunch of different risk factors that go along with it, and it's depends on the environment. So there's not one pathogen. It's more of a biofilm that's working together that will cause the disease, and it's just kind of sitting there waiting to work. And as soon as the environment changes, then that pathogenic biofilm can initiate the disease. So the goal of CAMBRA is to determine which of one of the many factors that cause the disease is causing the disease to be expressed, and then knowing that, then we can take appropriate action to address that causative factor or those causative factors and stop or reverse the disease. So it kind of, in some ways, it kind of makes the job easier. In some ways, it makes it a little bit harder. It makes it easier in that you can stop the disease and you don't have to go to heroic lengths trying to save horribly damaged teeth. It makes it harder because now you have to identify the disease sooner and you have to figure out what's actually going wrong rather than just filling holes in the teeth. So, but it shifts it from a treatment, surgical sort of a model to more of a preventative model or a preventative wellness model. Okay, so why do we go through all this? Why don't we just do it like we've always done it and just fill holes in teeth? One of the reasons is that research has shown that treating the symptoms of the disease does not stop the disease. It just masks it over. So we need to treat the disease itself rather than waiting for the disease to destroy stuff and then just fix the parts that it destroyed. So, but the reason that we need to assess this regularly is because a person's caries risk changes. It's dynamic. Because there's so many different things that caries depends on. There's many things that can change, but when your diet changes, your caries risk changes. If you get a new medication prescribed to you, your caries risk can change. Behavioral changes will cause your caries risk to go up or down. So caries risk is dynamic. Probably your caries risk a few years ago, when you were living at home and your mom was doing all your cooking, probably your caries risk was a little bit lower. Now you're on your own, you're studying all the time, trying to stay awake. I have an idea maybe there's some things that have changed that have caused your caries risk to go up a little bit. When you get closer to my age, you start getting a list of medications and your memory starts going away also, so you need to put all your medications on your phone just so you can remember what you're taking. But over half the medications that people take cause xerostomia to some extent. So as your caries risk is going to change like that also. Yeah, and then behavioral changes. Let's see, what would be a behavioral change? But again, going to school causes some behavioral changes. Moving to a new home, new places will cause behavioral changes. So we need to assess our patients' caries risk often because it's probably not the same as the last time that we saw them. Okay, so how often is often? Probably every 6 months or so for your normal patients. So every time you do an exam or a recall exam, you need to have just like you check the periodontal pockets every time. Doing the caries risk assessment should be part of that every exam. And you need to do your caries risk assessment after you've looked in the patient's mouth. I have some dental students who do their caries risk assessment and then have me come over to look at it, and they haven't even looked in the patient's mouth yet, and so they don't know if the patient has any existing fillings or existing carious lesions or not. So you have to look in the patient's mouth. You have to look at the radiographs before you can complete your exam. So for us, we do it in Axiom, but whatever electronic health record you're using or paper charts, but your caries risk assessment is part of the record. It goes into the patient chart. So for us, they've made it a little bit easy. They just put it in as part of the comprehensive oral examination or the periodic oral examination. So that code is just in there automatically, and then you can just fill it out as you go. So these highlighted ones down here are all part of the comprehensive oral exam, but the caries susceptibility tests are right in there with it. How does it work when you guys are doing your exams on clinic? Are they having you do the caries risk assessment as well? No.
Briefly.
Yeah, a little bit. So, yeah, you guys will need to, when you get into private practice, you probably get some sort of routine where either you're doing it or the dentist is doing it or you're splitting it up. But you should, yeah. It's more efficient if you're involved in the process. So if you have a smart dentist, include you in the process. Okay, at the end of it, there's, or no, this is at the beginning. So this particular caries risk assessment goes through the existing lesions, goes through the different disease indicators, the risk factors, protective factors. So just like any good caries risk assessment, this hits all those things. This one is a little bit longer than most that are used in private practice, because we also use this for, they want to be able to get some data out of it. There's how many different schools? There's a bunch of different schools using this exam, so there's a lot of data being put into it. But most caries risk assessments are not as detailed as this one. Okay, so at the end of the caries risk assessment is a place where you can put in the salivary analysis. So you can do the tests, the different tests on the saliva, and then once you've done all of those, then the computer will do a calculation and it'll say if the caries risk is low or high or moderate or extreme, and then you have to use your judgment to see if the computer is actually correct or not, and then from there you look at it to see what's out of balance, and you can make treatment recommendations for your patient. But what the caries risk assessment does is basically weighs the disease indicators and the risk factors against the protective factors. And so it's kind of like a teeter-totter. If you have more disease indicators and risk factors and not as many protective factors, then it tends to weight it towards a higher caries risk. If you have more protective factors than disease indicators and risk factors, then it tends to weight it to more towards a low caries risk. So it just weighs these against each other. But the idea of a teeter-totter is kind of illustrates that it's a dynamic process. So as these things change, then that risk goes back and forth. But it's the environment that determines how the biofilm is going to react, and this is what determines that caries risk. So let's go over some of what makes up these different components of this balance. So disease indicators are just clinical signs that the Caries disease is present or has been present. They don't really tell you anything about what caused the disease. They just say that there's been disease there. These are our best predictors for future Caries disease. Unless something has been initiated to change the patient's Caries risk, having evidence of disease previously is a pretty strong indicator that you're going to have disease in the future unless we change something. So one of the first disease indicators would be white spots on the teeth. So once you've cleaned and dried the teeth, having a white spot on the lesion or on the surface of the tooth would be a disease indicator. So looking at this white spot lesion here, is that an active Caries lesion or an inactive Caries lesion? The correct answer is you don't know, because it can be both. So what you really need is an explorer, and you can drag the explorer across that white lesion, and if it's nice and smooth like this picture is, then it's a remineralized white lesion. If it's kind of rough like the ball here, then it would be an active demineralized lesion. So all you can say from looking at this is that there is either active Caries or there has been active Caries in the past, but without checking that surface quality, you can't say whether it's active or inactive at this time. So you notice that I didn't say you take your explorer and you stick it into the tooth, because then you can just so if it is an active lesion and you poke at it with your explorer, it's already demineralized, it's already a little bit fragile, and you just took a non-cavitated lesion and turned it into a cavitated lesion. So you just want to be careful with your explorer or your curettes or your scalers when you're scaling these types or looking at these types of lesions. Okay, other disease indicators. So if the patient has fillings, that's kind of a good indicator that there's been Caries in the past. So if they kind of made an arbitrary line, if that filling has been placed within the last 3 years, then it's an indicator of past Caries. Activity. So you have to be a little bit careful though, because if your patient comes in with a mesioincisal composite on number 8, you have to ask one more question. You have to ask, why did you get a filling on that tooth? Because maybe he was like a lot of the young boys that I grew up with, and so they were always playing hockey, and they kept eating hockey pucks. So that wouldn't be an indication of Caries disease. That would be an indication that they weren't wearing their protective equipment like they were supposed to when they were playing hockey. So you have to ask, or maybe they just had a crooked tooth and they had a composite placed on there to make it look a little more like the other teeth. So you have to ask, why did you have the filling put in? Okay? And then your radiographs would be another way to find evidence of disease, but your intraproximal lesions on the radiographs would be another indicator of Caries, the disease. And then cavitated lesions. So obviously having any holes in the teeth would be indications of previous disease. Okay. So here's another picture of cavitated lesions. But yeah, these are the lesions that your patient points out to you. They say, "Doc, I have a hole in this tooth," and that would be an indication of caries. So your disease indicators are white spot lesions, recent restorations, enamel lesions, or cavitated lesions into dentin. So it makes this cute little acronym that helps you remember that it's not good for your teeth, but this wrecks your teeth. But these are the disease indicators. And these would make the caries risk increase. Other things that will make the caries risk increase would be obviously risk factors. So these are biological factors that are actual causes of the caries disease. Okay. So these are a little bit more informative for us, because instead of just kind of stating the obvious that the patient has the disease, these give us an idea of what is out of balance. And knowing what is out of balance, then it kind of suggests how that balance can be corrected. So these risk factors are the actual causes of caries, the disease. So obviously we spent a whole lecture talking about bacteria or bad bacteria, but bad bacteria are a cause of caries. Okay, so any cariogenic bacteria. Xerostomia, we ran over that last week as well. Hyposalivation is a big indicator for, or is a big risk factor for caries. And then bad dietary habits. So either eating too often or eating the wrong things will both cause your caries disease to go up. There was a researcher who made a model of the oral microbiome, and he was able to demonstrate that just by increasing the frequency of the meals, it would change the oral biome from a healthy biome to an unhealthy biome. So once the meals got closer than about 6 hours together, the bile would change to a cariogenic biome. So it's important when you're asking about diet, not only asking them what they eat, but how often do they eat? Are they giving the environment in their mouth a chance to recover to a healthy level, or are they always pushing it over to that unhealthy state? Okay, so if you have bad bacteria and an absence of saliva and dietary habits that are poor, obviously that's bad for you. So these would all cause your caries risk to increase. Okay, so we've talked about kind of all the things that make it worse. What makes it better? These would be your protective factors. And they've kind of clumped both the biological protective factors and the therapeutic protective factors together. But anything that's going to lower your caries risk is put into these protective factors. The more severe your caries risk is, you're going to have stronger, or the more, maybe I should put it the other way, the more risk factors that you have for caries, and you're going to have stronger protective factors to balance that out. So if you have absolutely no saliva at all, maybe you have Sjogren's disease, or you had radiation that destroyed the salivary gland, you're going to need some really awesome protective factors to balance out your caries risk. Bless you. Okay. So what are some of the protective factors? So obviously having good quality saliva and enough saliva. the will help protect your teeth. Sealants kind of got put in with the saliva as well. I saw somebody sneezing.
Oh, Hannah did, but
Did you need
We're
it?
all sneezing.
You're all good? So they put saliva and sealants together, not because they're the same, but because they both start with S. But having sealants on your teeth will definitely, there's been a lot of good evidence that has shown that this will lower your caries risk as well. Even a sealant that's partially retained is going to protect the tooth more than having no sealant at all. So, and it doesn't matter. There's some research that says that maybe glass ionomer sealants work a little bit better, but when they've done the systematic reviews and put all these different studies together and done the meta-analysis, they haven't been able to find too much difference between what type of sealant. So whether it's a resin sealant or a glass ionomer sealant, they all protect the teeth. Antimicrobials. So if you have high levels of strep mutans and lactobacillus in your mouth, then to protect against that, then you're going to need an antimicrobial to address that. You guys know what this is. You guys use the Paradex quite a bit. It's a very good antimicrobial. What are some of the downsides of Paradex or chlorhexidine? Yeah, so you can get some tooth staining. So you typically limit it to how long? How long do you use chlorhexidine for? Yeah, so about 30 seconds at a time, but you try to keep it less than 10 days. Keep it from staining the teeth too much. Paradex is a broad spectrum antimicrobial, so it kills everybody. So it kills off the strep mutans and the lactobacillus, but it also kills out all the healthy bacteria as well. So what is in, and then there's lots of evidence that shows that once you've killed all the bacteria, if you don't do anything different, within 2 weeks that same bacteria, that same biome is going to grow back. So antimicrobials are only half of the solution to the problem. Once you've gotten all the weeds out of the garden, you have to do something different so that you get flowers that grow back instead of weeds or tomatoes, or in my case, cactus. But anyway, so the antimicrobial is only half of the problem, or half of the solution. You have to change the environment so that the healthy bacteria will grow back. So Paradex is a very common antimicrobial that you all have used already. Some other ones would be sodium hypochlorite or bleach. You've all used bleach at some point, I'm sure. But using a dilute sodium hypochlorite solution will work really well as an antimicrobial in the mouth. Hydrogen peroxide will kill off bacteria, but it's pretty hard on the oral structures as well, so we don't recommend hydrogen peroxide too much. The one that we recommend on clinic, mostly because of the way it's packaged and it's easy to buy, is the Caries-free rinse. But that's a solution of sodium hypochlorite with some xylitol and some fluoride and some other stuff in it. But that's another broad spectrum antimicrobial. There are some antimicrobials that aren't broad spectrum antimicrobials. There's a lollipop. Let's see, do I have a picture of the lollipop? So yeah, so we don't recommend the broad spectrum antimicrobial all by itself because it's only half of the solution to the problem. You have to do something to change that environment so that the good bacteria are going to grow back. Lolos are a lollipop that we prescribe to our patients. So first time you prescribe a lollipop to your patient, they look at you like you're kind of crazy. It's like, the dentist has never given me cavities or candies before. But these lollipops are made with an extract from Chinese licorice root, and it's been shown to be very effective at killing strep mutans. So if the patient's bacteria, if they have a lot of strep mutans already in their mouth, then this will lower their counts of strep mutans. But it has to be specific to your patients that have just high counts of strep mutans, because if they happen to have maybe high counts of lactobacillus, then this isn't going to work as well. Or if they, and then remember that in a slightly acidic environment, other bacteria can adapt to make the environment more acidic also. So having a antimicrobial that's specific against one bacteria can be helpful in very specific cases, but in general, because there are many different bacteria that can contribute to caries, the disease, it's not a good choice in general, but for specific cases it will work really well. Let's see, what else do we have? Synodent is a mouth rinse. It's a very basic mouth rinse, but they incorporated chitosan with arginamide in it, and the chitosan is found often in seashells, and it's what they use to attach to rocks. But what it does is it makes it harder for the bacteria to attach to the tooth. So, and then it has the arginine in it as well, so it tends to favor the non-cariogenic bacteria. And it's very basic. What else do we have? Basic bites. These have some arginine in them, so they tend to favor the non-cariogenic bacteria over the cariogenic bacteria. So they will switch the biome for you as well. They're little chocolate chews that have a bicarbonate in them. So they're very basic. So again, your patient is going to look at you a little funny when you tell them that you want them to eat a little bit of chocolate every day. But having the bicarbonate in there, along with the arginine, is going to help to shift that biome from an unhealthy biome to a healthy biome. So this tree, so the scientific name is Salvador persica. In some areas of the world they call it the miswak tree. I actually ran into this when I was working in Africa. So a lot of my patients would be chewing on sticks to brush their teeth, and I thought, well, okay, it's a stick, it's rough, it's cleaning this stuff off their teeth, it's probably not doing too much harm, except that it's actually has antimicrobial properties in the tree itself. Both anti-carcinogenic properties, as well as it works against the periodontal bugs as well. So you can get toothpaste that has the extract from it in it. Probably not from Stater Brothers. Maybe you can find some in Clark's or something like that, but it's not really mainstream. But the miswak root has been shown to have some anti-carcinogenic properties in it. Okay, so we went over the saliva and sealants and the antibacterials. Fluoride. Fluoride is a very strong protective factor against caries. So if your patient is using fluoride in their toothpaste, and if they're drinking fluoridated water, this is definitely going to lower their caries risk. There's some other things that work with fluoride and will lower the caries risk even further. One of those is the MI paste is, let's see, ACP, amorphous calcium phosphate, ACP, CPP. What is the last half of it? Anyway, it's a lot easier to say the MI paste, but the MI paste is calcium and phosphate wrapped up in a casein protein chain. This protein chain changes shape in the presence of low pH. So when the pH gets below about 6.7, the chain unwraps and releases the calcium and phosphate into the environment. So it's kind of like a just-in-time toothpaste. Bless you. Because just as the pH drops, you get a bunch of calcium and phosphate dumped into the saliva. So it tends to raise the buffering capacity of the saliva. Other things that can be added to fluoride to decrease the let's go back. To decrease the caries risk would be nanohydroxyapatite. So nanohydroxyapatite tends to lower a person's caries risk because it's just some bioavailable minerals that will help to remineralize the teeth. Okay. So when we talked about fluoride the other day, we talked about how it gets incorporated into the tooth structure of a newly erupted tooth, and we talked about how it makes the developing tooth stronger by being incorporated into the hydroxyapatite. But that's not the same way that fluoride protects your tooth once it's been out in the oral environment for a long time. So when you put fluoride on a tooth, it makes a little fluoride plaque on the surface of the tooth, and then it combines with calcium and phosphate in the saliva to make this fluoride plaque over the top of the tooth. So that if the pH in the environment drops, then that's where the tooth demineralizes first, is from that little fluoride plaque covering the tooth. So there's two different mechanisms for fluoride protecting the tooth. The one is when the tooth is developing and it gets incorporated into the structure of the tooth. Once the tooth has already erupted, then it acts as a mineral reservoir on the surface of the tooth. That's why when you put fluoride varnish on a tooth, you don't want the patient to eat or drink for 30 minutes or so, because you want that plaque to develop on the tooth. Okay. There is a thing called occult caries, and it can be caused by fluoride. So in very specific situations, fluoride can actually cause the teeth to demineralize. So if your patient has a slightly acidic saliva, so maybe 6.7, 6.8, just a little bit acidic, and they have poor buffering capacity, so not a lot of calcium and phosphate in their saliva. If you put fluoride on the teeth, it can cause caries because the fluoride loves calcium. So when you put it on in a normal healthy mouth, when you put fluoride on the teeth, it takes the calcium from the saliva and makes that little fluoride plaque over the top of the tooth to help protect the tooth. In the specific case where I was talking about, where the saliva is slightly acidic and the patient has low buffering capacity, so not a lot of calcium in the saliva, you put fluoride on the tooth and it's looking for calcium, and it can't find any in the saliva, so it goes to the next best place, which is that tooth that you just put it on. So it will pull the calcium out of the tooth to because that's what fluoride does. It likes to bind to calcium. So it pulls the fluoride out of the tooth, and it can cause a lesion, a demineralized lesion on the tooth. So this is called occult caries. So it happens under very specific circumstances, but it's why you probably should know what your patient's pH in their mouth is and what their buffering capacity is before you put fluoride on their teeth, because in some cases you can actually make things worse instead of better. But you probably want to remember occult caries. Not that it happens a lot, but it's going to happen probably next week at least. Okay. And then just like bad dietary habits will cause your caries risk to go up. Good dietary habits are going to cause your caries risk to go down. So what are the two things that you have to ask when you're asking about dietary habits? What's the first thing? Yeah, what do they eat and how often? Okay, so good dietary habits. What would be the frequency of good dietary habits?
When you eat.
Yeah, so longer times. So are they eating every 6 to 8 hours, or are they eating more frequently than that? Your diabetic patients, how often do they eat? Yeah. So diabetics, they don't have the insulin to help regulate their blood sugar, so they tend to eat smaller meals more frequently. So is this a good thing for their teeth or a bad thing for their teeth? Bad. Yeah. So this raises the caries risk for diabetics. Which brings you to the second question: what are they eating? So what do your diabetic patients eat? What do they tend to eat? No, they don't eat any sugar. So they tend to eat foods that are less cariogenic. So even though your diabetic patients are eating more often, they're usually eating food that is less cariogenic. And so that's why diabetics don't, because you kind of expect them to have really high caries risk, except for even though they're eating good foods or eating so often, they're eating good food, so it kind of balances itself out. And you definitely don't want to tell your diabetic patient that you can't eat so often, because you will make your physician quite upset with you, because their blood sugar is going to start spiking and they're going to get out of control, and you're going to cause even more problems. But yeah, so good frequency, less than or more than 6 hours. Good foods. What would be some healthy foods as far as caries goes? Unless you're looking at the next slide. So foods that are low in simple carbohydrates and high in proteins, but especially arginine. We talked about arginine last week, and the arginine deaminase system. It takes the protein and breaks it down into what? You remember from last week? No? Yeah, so urea and ammonia, which causes the pH to go up. That'll be another good thing to remember for next week. But the arginine, so foods that have lots of arginine in them, I Googled it the other day. The food that has the most arginine in it is liver from a sea lion. Not that I would recommend that to anybody, but I guess somebody measured it. Other foods that have lots of arginine in them, turkey. You can go to, if you get a smoothie, lots of times they'll have little things that you can put in your smoothie to make it more healthy for you. Spirulina is one of the things that are often added to a smoothie, and it has a lot of arginine in it. There's about 4.5 grams of spirulina in every cup of arginine, or of every cup of spirulina. Hopefully they don't put a cup of spirulina in your smoothie. It's going to make it taste kind of gross. They probably put a little bit in it, so you're probably not getting a ton of arginine from your smoothie. But some other things that are very effective as far as having arginine in them would be cheese and nuts. And these are things that if your patient has a snacking habit, instead of telling them don't snack, maybe just having them switch to a more healthy snack like string cheese or mixed nuts. And at least it will help to get a little more arginine in their diet and maybe make it a little bit more healthy for them, less cariogenic. Pumpkin seeds, garbanzos, lentils. Well, we can't say anything about that. Soybeans, chicken, they all have a lot of arginine in them. Okay, so when you're spinach, seafood, you all tend to have a lot of arginine in them. So if your patients want to know what they should eat, this will give them some. But you notice there's no crackers in here, no breads, all those easily fermentable carbohydrates. So staying away from those, staying more with the protein-rich foods is going to increase a person's resistance to caries, so lower their caries risk. Okay? And then having regular recalls. So if your patient is coming into the office and they're getting regular recare appointments, this is going to lower their caries risk because you guys are going to be assessing their risk factors and their protective factors every time they come in for their recare appointment, and you're going to help them to keep it under control. So a person that comes in every 6 months for recare is going to have a lower caries risk. Okay? So people often ask me, so what's the difference between CAMBRA and a caries risk assessment? Because sometimes they get mixed up and people start thinking that they're the same thing. So CAMBRA is a kind of a treatment philosophy. The caries risk assessment is a tool in that treatment philosophy. So when you're managing a person's caries disease by risk assessment, part of that management is the risk assessment. So we've been talking a lot about the risk assessment because it's such an important tool in managing caries the disease. But a good caries risk assessment gathers all the information needed to diagnose the disease, and it lays it out in a manner so that you can see what factors are out of balance, what factors are protecting. It makes it easier to kind of get a mental image of where that teeter-totter is. Is it on the caries risk side, or is it on the the protective side. So a good caries risk assessment looks at the historical data, because unfortunately that's our best predictor for the disease right now. But it looks at medical history, so what kind of surgeries, any radiation, any medications that affect the caries risk. You're going to look at dental history, so what has their previous caries experience been? You're going to look at their social history. Recreational drugs, smoking, alcohol, all of these are going to raise the caries risk assessment. You're going to, again, dietary history is really important. What do they eat? How often do they eat? Going to look at their oral health care habits, other personal habits. I had a patient who ate clay. She was prescribed clay from her village healthcare professional, and there was probably some good things about the clay. Clay tends to be very basic, so that was probably good. It was very abrasive, so it wore her teeth away really badly. But yeah, so some funny personal habits. I think I told you about did I tell you about my little 4-year-old that came in and all of his teeth were eroded? I told you guys about that one. Yeah, because he didn't want to swallow his apple juice. He would just hold it in his mouth. And I couldn't figure out why this little kid was having so much erosion on his teeth, but talking to mom, asking her what he likes to eat, and she's like, yeah, he's so weird, he won't swallow his juice. Okay, well, what you gonna do? But yeah, personal habits, so cultural habits. There was a group of people where I lived in Cameroon, and they would file their teeth down because they thought it was prettier. But they exposed all the dentin when they filed their teeth down, and so it was easy for them to get decay in them there as well. So you'll find some funny personal habits that will affect caries risk also. And then the salivary tests. So after the midterm, the next week, we're going to do some salivary tests on each other. Or actually, you will do salivary tests on each other. I probably will just watch. But I'm checking the salivary flow rate, checking salivary pH, checking buffering capacity, checking for evidence of bacterial metabolites or measuring bacteria directly. All of these things are going to give you an idea of what the patient's caries risk is. But the important thing to remember is that caries risk changes over time. So you can't, it's just like blood pressure. You don't measure a patient's blood pressure one time and then just assume that they have good blood pressure every time they come in to see you, but you measure it every time they come in, but frequently, just to make sure that it's not changing. Because caries risk is the same way. Your risk of hypertension changes, your risk for caries changes as well. So it needs to be reassessed regularly. And hopefully, when you guys are doing this, you're making their caries risk change in a positive manner. So if you're practicing Canberra in the way it's meant to be practiced, your patients, their caries risk should go down, right? Because you're going to be making recommendations, helping them make the effective changes in their life, reassessing it, making sure that it's working. So you should be changing their caries risk. There are about as many different caries risk assessment forms out there as there are dentists. So just using these principles and making sure that your caries risk covers all these different things, but it has to be, you don't want it to take 40 minutes for the patient to fill it out, so it has to be something that's easy to use. But it has to cover all the essential details as well. There's so many caries risk assessments out there that not all of them have been studied to see if they're effective. But the ones that have been incorporated into studies and deemed effective, they do have all these, they cover all those essential elements. So as long as your caries risk assessment isn't missing disease indicators or risk factors or protective factors, it's probably going to do the job. And we have evidence that shows that these measure a patient's caries risk effectively. So being an older dentist, when I graduated, we didn't have the caries risk assessment, but you kind of got you had your own little seat of the pants caries risk assessment, but it wasn't documented, and you couldn't go back and check, what was my patient's caries risk before, and is it better now? So having something that's documented in the patient record lets you go back and see what changes have been made, how it's getting better, and it makes it much more effective that way. But the CRA form just allows you to put all this data that you've collected into one place. It allows you to visualize that caries risk balance a little bit better. So your high-risk patients are those where you have disease indicators and risk factors that totally outweigh the protective factors. And then on the other extreme, you have the low caries risk patients where they just have a bunch of protective factors and very few risk factors and maybe no disease indicators. It's the moderate risk patients where you have kind of a mix. You have some risk factors and some protective factors, but they kind of balance each other out. So these are your patients that are of moderate risk. And then some people add a fourth category in there, the extreme risk patients. These would be your patients that are kind of out of the norm for one reason or the other. Most of the time it's due to salivary dysfunction, but other extreme risk cases would be people who use recreational drugs like methamphetamines. Those are, if you've ever seen a person with meth mouth, you can see how that would be considered to be an extreme caries risk. Early childhood caries is another form of caries that just progresses really rapidly. So that would be another example of an extreme risk patient. So let's see, when was this? This was back in 2011. But Dr. Featherstone was able to put in the, let's see, I think it was up in San Francisco. I think it was University of the Pacific. But they measured people's caries risk and then measured how many of those people got caries lesions within the next year. So for your low risk patients, even though you're at low risk, still almost a quarter of the patients developed a carious lesion within the next year. So even your low risk patients, just because they're at low risk doesn't mean it's zero risk. So they're still at risk for developing a carious lesion. Your high-risk patients, in this study, about 70% of them developed carious lesions within the next year. And with your extreme risk patients, just about all of them, almost 90%, developed caries within the next year. Okay. Oh, that changed sooner than I wanted. So, but as you can see that a caries risk assessment is a predictor for the likelihood of developing caries in the future. Okay? And as your risk goes up, the likelihood of getting decay within the next year goes up as well. All right, here's a busy slide. There's a lot of information in this one. But back in 2007, so that's like 12 years ago, the California Dental Association published intervention protocols based on a patient's caries risk. So caries management by risk assessment, basically, is what the CDA came up with. They came up with very specific treatment protocols based on the patient's caries risk. So they had one so this is for the children 0 to 5 years, and then they had one also for patients who are older, so 6 and up. So a few interesting, there's a lot of interesting things in here, but for your low-risk patients up there, you can see that they have frequency of radiographs. So when you go into the dentist, how often do they tell you you need x-rays? Yeah, some people are like once a year, some people are like every 6 months. If you ask the office manager how often should we take x-rays, he's probably going to say, well, let me check their insurance. But if you're doing caries management by risk assessment, your frequency of x-rays is based on the patient's caries risk. So for your low caries risk patients, they're recommending x-rays every 36 months. So every 2 to 3 years is what they're recommending, which is a really big interval between x-rays. But it makes sense if your likelihood of getting caries is low, then the risks of doing x-rays probably don't outweigh the benefits of detecting new carious lesions. Caries isn't the only disease that we use x-rays for. You guys look at bite wings all the time to see what? Nobody? Bone level, yeah. So for their caries risk assessment might say that they don't need x-rays except every 3 years to determine if there's any new caries. You may want to take them more often if they have periodontal disease and you're trying to assess bone levels. So this is only related to caries. If they have other diseases, you may need x-rays more often than that. But as you can see, as you come down, the frequency of x-rays goes up until you get to your extreme risk patients, and then they recommend x-rays every 6 months, and sometimes even more often than that. Because when you get into the extreme risk patients, their caries, those lesions are progressing super rapidly. Excuse me. Okay. Same thing with frequency of recall exams. For your low caries risk patients, maybe you'll do your recall exam every 6 to 12 months to reevaluate their caries. But if for your high risk patients, you're going to have them on a really short leash, and maybe you're going to see them every 3 months or maybe even every 2 months until you get the disease under control. And again, if there's other diseases going on, like periodontal disease, you may want to see your low-risk patients more often to evaluate those other diseases as well. But these protocols are they're talking specifically about the caries. So they're very, very specific about that. And then it just goes the same way all the way over. So whether or not you do salivary tests is dependent on the patient's caries risk. Whether or not you give them fluoride is based on the patient's caries risk. if you're giving them other supplements like calcium or something. It's all based on the patient's caries risk. When I graduated, we kind of thought that we should just throw fluoride bombs out there and put fluoride on all the patients. But according to the CDA treatment protocol guidelines, whether or not you use fluoride is, again, based on the patient's caries risk. And then sealants. We used to do just sealant clinics where we would go to a school and put sealants on all the kids' teeth. And it was probably effective to a certain degree, but it was maybe a waste of resources, because if you have a patient with a low caries risk, putting sealants on their teeth isn't really going to make their caries risk go down any, and it's just going to cost money and annoy the children. So again, sealants should be applied based on the patient's caries risk. So it's kind of a recurring theme here. Okay. But yeah, as that risk goes up, these different, whether or not you use these protocols increases as well. So back to that teeter-totter, the bigger your caries risk, the more protective factors you're going to need to help to balance that out. Okay. So Mrs. Hurlbut and Dr. Young, they kind of made a similar chart, but it's not as busy, so it's a little easier to follow. But they organized it in a little different way. But they kind of organized the patient's caries risk against the safer protocols that came from that caries risk assessment teeter-totter. So the saliva and the sealants, the antibacterials, fluoride, or other adjuncts, and then the effective lifestyle habits, the diet, and those things. So they put these treatment protocols, but again, they balance them out against the patient's caries risk. And so it just makes sense. You identify what's out of balance in that teeter-totter, and then you fix it. Okay, and hopefully by fixing it, you get to fix what's causing the disease instead of having to fix the teeth later on. But some of the clinical interventions that we have when we identify what's out of balance. So if the patient has low salivary pH, we add something in there to make the pH come up. So you can use something like the baking soda, which is just very basic. So you can add some sort of basic mouth rinse to make the pH come up. This is kind of a short-term solution, just like when you eat and your pH drops and then it comes back to normal. If you rinse with baking soda or any sort of something that has a very basic pH, it will raise your pH, but then it's going to come back down. What we've seen is that it usually tends to come back to what your baseline was within 2 hours of rinsing. So if you really want to alter a patient's oral pH, they're either going to be having to rinse every 2 hours, or you're going to have to do something different. So the basic bites is kind of similar, except it has arginine in them. So you get that initial increase in pH, but it also has the arginine that's going to help to shift that biofilm to a healthy biofilm. And then the xylitol is another example of shifting the biofilm. So it's not going to take effect right away, but over time, adding more xylitol to the diet is going to shift the biofilm to a more healthy biofilm. when we talked about the MI paste and how it increases buffering capacity. So if you measure the patient's buffering capacity and it's low, then adding some MI paste to the patient's treatment regimen would be important. So what kind of protein did I say that the MI paste wraps the calcium and phosphate in? Casein protein, yeah. So that's really important. Last quarter, there was a little girl in Orange County who was prescribed MI paste. And the doctor either forgot what was in her health history or he didn't ask, I'm not sure. But the patient had a milk protein allergy. So casein is a milk protein, and this little girl got an anaphylactic reaction, and she ended up passing away. So you have to remember, even these, and the patients were like, or the parents were like, well, it was a toothpaste. Everybody uses toothpaste. We didn't think that it would have milk in it. But even these common things that we prescribe, there's also been reports of adverse reactions or allergies to chlorhexidine. So reviewing the patient's health history is really important. But if your patient is lactose intolerant, can they use the MI paste?
Yeah.
Yeah. So if they're lactose intolerant, they can use the MI paste. But if they have a milk protein allergy, that's a severe contraindication. Okay, that's it. The MI paste works really good when it's indicated, but you just have to you have to be careful. Okay, so if when you do your salivary analysis and you note that the patient has high levels of pathogenic bacteria, then you have to do something to decrease those levels of pathogenic bacteria. Like I said, this gets a little more complicated because you just can't kill the bacteria because the same bacteria will grow back again. So you have to kill the bad bacteria and then make it easier for the good bacteria to grow back. So usually it involves some sort of antimicrobial and then some sort of commensal nutrient for the good bacteria to grow back. So what we use on the clinic is the Caries free rinse because it has the sodium hypochlorite in it as well as the xylitol all together. So it does both of those things at the same time. If you're going to use chlorhexidine, then you're going to have to add in some sort of xylitol component or some arginine component to the treatment. Because the chlorhexidine tends to stain the teeth if you use it for more than about 10 days. If you're going to use chlorhexidine to lower a patient's pathogenic bacteria, usually what they do is they have the patient rinse for the chlorhexidine for a week, and then they have them use xylitol products for the next 3 weeks in the month. And then the next month they do the same thing. So xylitol or chlorhexidine for the first week, and then xylitol products for the next 3 weeks after that. And then they do that for about 6 weeks, and then they measure and they redo the salivary tests again to see if they've lowered the pathogenic bacteria or not. Yeah, so it's a little more complicated because you have to kill the bacteria, but make sure that the good guys grow back.
So you were saying the lalos, the suckers, or whatever, those ones kill mutants. So if like the bacteria test comes positive with a lot of mutants, they just have to use that and then that'll kill it, or do they have to also use something to help regrow the good bacteria?
So good question. So you guys here in the back. So the question was if the Lolos kills just the specific bacteria, do you still have to nurture the good bacteria? And the answer is probably yes, just so that because you, yeah, you want, so when we talked about bacteria the other week, we talked about how the patient develops their immune system and how they recognize self within those first 3 years of life. Most of your patients are going to already have recognized that their oral biome as normal. And so when you try to change it, they're going to want to bring back that normal biome, even if it's an unhealthy one. So yes, we probably, to help make that shift, probably have to make sure that the environment changes. So adding food that the good bacteria like, or increasing the pH, making it more basic so that it's harder for the acidogenic bacteria to grow back. Those would be more good
The
things.
Caries risk assessment within Axiom, where is that? What's inside that?
So if you go, it's under a Caries susceptibility test, so you're looking at it right now
Yeah.
in Axiom. If you search Caries susceptibility tests,
Search that? Where is
add the code.
Oh, I don't know.
This one.
Go plus sign there. Add the code. Caries susceptibility test, it's going to pop those up for you. That's probably more important for you on clinic. I'm not going to test you about Axiom. Axiom tends to frustrate me a little bit, so I'm not going to ask you questions on the exam about Axiom, but I want you to understand the principles and how these Caries risk assessments work. Other things that could shift the bacteria to a more healthy bacteria. We went over the Lolos, the Synodent rinse, the miswak roots will shift the biofilm. The dietary counseling, so xylitol, arginine, diets that tend to be higher in protein, lower in simple carbohydrates, frequency of meals again. And then for your patients, so if you thought bacteria were hard to deal with, your patients that don't make saliva, these are the really difficult ones. So this is where you earn your money. Because there's a bunch of different products out there that are advertised as saliva replacements, but they really don't replace the saliva. They tend to make the mouth feel more wet, more lubricated, but they don't have that 1% of the saliva that has all the important stuff in it. So they don't have the salivary proteins, they don't have the immunoglobulins, they don't have the calcium and phosphate in them. So the saliva replacements like biotin just tend to make the mouth more wet, more slippery, which is, and it's a really important thing, but it's only half of the solution. But it at least allows the patient to move their tongue around, to chew their food. It makes the patient much more comfortable, but it doesn't protect the teeth as much because it doesn't have the sialin or the histatins or the immunoglobulins that we talked about last week. So you have to replace, it doesn't have the minerals, so you have to replace those minerals. So something like the nanohydroxyapatite or the MI paste is going to help to replace those minerals. What we use on clinic would be the Carie-free gel that has the fluoride and the nanohydroxyapatite in it to help to replace some of those minerals that are missing. If your patient has some salivary function, and this would be something that you would measure, so you could chew on the unflavored gum and you'd see how much saliva they produce. If they can produce some saliva but not the the 0.7 mils per minute that would be considered normal. But they just need a supplement, and having them suck on a lozenge to help to stimulate that saliva, or chew on gum to help stimulate the saliva could help them. So the Xylamelts are a lozenge that has some xylitol in it, and the interesting thing about the Xylamelt lozenges is it has a sticky side. So the patient can use it when they're asleep because it will stick to the ridge of the jaw, and they don't have to worry about breathing it in during the middle of the night. But like I said last week, salivary production goes up and down. Usually tends to be lowest in the early morning hours, like 2 or 3 o'clock in the morning. So having a lozenge in there that will just kind of melt away and you don't have to worry about aspirating it is very helpful. And this does make a lot of saliva. I got some and I tried them and I was drooling all over the place. So it does stimulate saliva. A very potent salivary stimulant would be pilocarpine, and it will stimulate salivary production. You can use it in a topical form, so that you can go to the compounding pharmacy and have them make a pilocarpine lollipop, and they'll put some pilocarpine and some xylitol and some flavoring into a lollipop. The patient can lick that, put it back in the little prescription bottle, but it will stimulate the saliva. Or you can use the pilocarpine systemically, so they can just swallow the pilocarpine and it will stimulate the saliva. The problem with the pilocarpine, and the reason we reserve it for the very severe cases, is that if you can think of a side effect to a medication that you think might be unpleasant. So what do you think? What would be an unpleasant side effect? Well, that would, okay. That's the one, so xerostomia was the side effect and that's the one side effect that the pilocarpine doesn't have. It will stimulate saliva. Yeah. Yeah. All those things. Heat flashes, upset stomach, upset GI. Yeah, anything that you think might be miserable, the pilocarpine will do it. So we usually reserve the pilocarpine for those cases where we can't get anything else to work. The systemic pilocarpine usually has more severe side effects than the topical pilocarpine does. So usually we'll try the pilocarpine lollipop or the pilocarpine reds first. But the xerostomia usually has to be really bad before the patient will appreciate taking the pilocarpine. If you just give it to a patient who has a little bit of dry mouth, sometimes early in the morning, and you prescribe them pilocarpine, you'll probably just make them really upset with you. You will stimulate their saliva, but they probably won't appreciate it. Okay. So, clinical interventions. So once you figured out what's wrong with the patients, what's caused the Caries disease, then you can fix it, and then you can prevent Caries from developing in the future. And that's basically what Caries management by risk assessment is. You figure out what's causing the risk, and then you fix it. And then you reevaluate it to make sure that you really did fix it, or that the patient's being compliant, or whatever. Which is another thing that so we've been talking about prescribing this for the patient, prescribing that for the patient. But what this is doing is shifting the responsibility for treating the patient's caries from you guys, the dental healthcare professional, to the patient. And so now we'll talk later about how you have to empower the patient and how you have to teach the patient everything you know so that they will want to make these changes in their life. So, as you guys have already been dealing with patients and you know how important and how difficult patient compliance can be. But that's a whole nother lecture. Okay, we already covered all the exam questions unless you guys have some more exam questions. But again, 50 questions, you guys will have 2 hours, so plenty of time, multiple choice, based off of the lecture objectives. Tends to be challenging, so I would study hard for it because it tends to challenge some people. So if you've had troubles with the quizzes, it's going to be a similar difficulty to the quizzes. Any questions over today's lecture or anything in general? Yes?
So you said we will have a study guide?
No, you have.
Those are the study
So that
guides.
is the study guide, yeah, those lecture objectives. If I make you a study guide, it would be those three.
And the articles, like,
Articles are good background information, but I'm going to pull the questions off of those lecture objectives. Yes.
In terms of camera, how many dental, is it now a priority that dental offices do that?
Yes. So it's been those treatment guidelines that the CDA came up with. Those are 12 years old, but that is the standard of care.
I worked with a dental assistant for a while, and I've never seen it.
Yeah. So that's the other side of it. I think getting patient compliance is difficult. Getting dental professionals to change the way they've been doing things for the last 30 years, that's even more difficult.
I love the preventative experiment, but it doesn't seem like it's money making at all. Like, it would be, it's counseling and, a lot of therapeutic interventions, which is great. But that's awesome that they're doing this.
Yeah. So that touches on another thing for another time as well. But so if you're not doing fillings, how are you going to make money? So there are codes, that billable codes that you can do for the caries risk assessment and for preventative protocols. But just in general, if you treat, so this comes from one of those categories that I said was not as reliable, but from my clinical experience, if you tend to remineralize cavities or not do as many fillings, your patients talk to each other, to their friends, and just like you can get a bad reputation as a dental healthcare professional, you can get a good reputation, and they're like, well, this guy, he doesn't like to do fillings, or this lady, she doesn't do so many fillings, but she helps my teeth get stronger, and then you get more patients that way. So maybe you didn't make as much money on that first patient, but later on, your patient family is just starting to grow into you are making. But insurances are starting to. Okay, I got a little bit of time. But insurances are starting to change the way they reimburse for dental treatment as well. Because dental insurances have been watching how the camera protocols have been developing also, and so there are some dental insurances that are looking at how to measure if your patient is getting more healthy. So they are looking at your caries risk assessment and your diagnosis. And did your patient go from a from a high caries risk to a low caries risk. And then they reimburse you that way. So it's, so they're looking at it because insurance is, they might not care as much about the patient as you do as a healthcare professional, but they don't want to spend a lot of money. And so they don't want to reimburse for fillings and crowns if they can reimburse for something that is maybe not as much. So they're looking at this as well. Did that help your question a little bit?
Yes, it does.
Anything else? Wow. Okay, so again, I don't have a lot of office time. They gave me Friday afternoons for office time, but they keep scheduling meetings when I'm supposed to be in my office. So if you need to talk to me, come find me on clinic or in the freshman lab. You can just go to the DGD offices and ask where's Dr. Birch, and then Barbara will tell you where to find me. But come and talk to me if you have any questions. Don't be afraid. It might be scary looking, but I don't bite too hard. But yeah, if you have questions, don't hesitate.
I have it. I have Friday.